Good evening, everyone. This is Meldita and I'm back. And last time I spoke about ventricular tachycardia, which is a wide complex rhythm coming from the ventricles. This time it will be SVT with bundle branch block. SVT means supraventricular tachycardia, and with bundle branch block it makes it wide complex, but it's coming from above the ventricles. So the SVT comprises SA node. We have the from the atria, the AV node, and we have also the bypass tract of Wolff-Parkinson-White syndrome. So sometimes SVT could be short run, or it could be the whole rhythm will be in SVT with bundle branch block. Okay, so 3 or more consecutive beats, as long as the heart rate is more than 100 beats per minute. And the QRS and morphology. Normally, SVT is narrow QRS rhythms, and they are like 0.06 to 0.10 seconds. But when they have bundle branch block, their QRS will be wide. It could be either from the left or from the right bundle, and their QRS will be equal to or more than 0.12 seconds. The rhythm could be regular or irregular. It could be non-sustained, wherein the heart rate is less than 100 beats per minute, and there's palpitation. That's a problem. Not a big deal with this palpitation. The big deal is when it becomes sustained. When the heart rate is more than 100 beats per minute, there are symptoms besides palpitation like lightheadedness, dizziness, short of breath, and fatigue. The mechanism is the same as in VTAC. There's an enhanced automaticity. Reentry, which is the very common cause of SVT, for AFib, atrial fibrillation, atrial flutter, AVRT, or the atrioventricular reentry tachycardia, or AVNRT, the AV node reentry tachycardia. The trigger activity is less common. The onset, they can come quick. So in the case of acute MI, STEMI especially, AFib, rapid AFib can come quickly. That's because of fluid overload. When acute MI suffers, poor contraction because of infarction, they build up fluids, they stretch the atria, and they can provoke AFib or A-flutter to happen. Paroxysmal, usually these people have chronic AFib already, and sometimes they get burst of or proximal AFib. It comes quickly and disappears quickly. Permanent, these people are already suffering from lifelong symptoms of AFib or flutter, and they are considered permanent. Going back to the cause of SVT, which is reentry, that one. So the reentry, it could be AVRT, or it could be AV nodal reentry tachy. So the AVRT is the atrioventricular reentry tachycardia of Wolff-Parkinson-White syndrome. There is a connection between the atria and the ventricles because there is a bypass tract of the Wolff-Parkinson, and this is called the bundle of Kent. So impulses coming from the SA node will go down the AV node, that one antegradally. Other impulses will cross the bypass tract also here. They go down directly to the ventricle. As the impulses actually arrive here faster than the AV node because of the filtering effect of the AV node. It's slowing down here. Not all of the impulses will be allowed by the AV node to let go inside. So some of them are actually screened. So the impulses arrive at the ventricle, but the cell-to-cell conduction is slow, which is why we have the so-called delta wave. The activation of the ventricle here is slow but wide, typical of ventricular stimulation. But because some of the impulses come from the SA node, passing the AV node, we have a narrow QRS in here. So this is a hybrid or a combined stimulation of two stimuli here, one from the AV node and one from the ventricle. So we have this wide QRS in here. We can mistake this to as VTAC because there is an AFib with Wolff-Parkinson. So the second heart here is an orthodromic AVRT. So in this case, the impulses doesn't come from the SA node, but come from the atria. Some of the impulses, actually not some, all of the impulses will cross the AV node, going down to the ventricle. So we have a normal QRS looking because the impulses passes the AV node, but somehow the impulses will go upward and these impulses will stimulate the atria, which is why we have an inverted P. Okay, so if I'm facing this heart, this is clockwise. Okay, so that is orthodromic AVRT. When we speak of antidromic AVRT, the impulses will come from the atria. So they go the other way around. So they go past first, not from the AV node, they go past the bypass tract of the bundle of Kemp, of Wall Parkinson. They go down, they stimulate the ventricles, and here we go, we have wide QRS in here, and then the impulses will go upward and stimulate the atria, which is why we have an inverted piece. If the rate of this rhythm is fast, we don't see the piece, and the doctor will think like this is VTAC. The AVNRT is regarding the AV node issue here. So in here we have a normal AV node. So the AV node has two pathways in here. One is fast and the one is slow. The fast pathway has actually, it is a fast pathway, so all impulses will arrive fast, but somehow the recovery time or refractory period is slow. The other one is slow, getting in is slow, but the recovery is fast. So what happened is that if the impulses will come from the SA node, most of them, the impulses will go in here. There's a recovery, there is a refractory period. And then the other one, some of them will go here. By the time the recovery is finished here and try to get in here, the recovery phase of this fast pathway is already over. So this will be extinguished. And impulses coming here will go down to the ventricle to stimulate it. Okay. With regards to this one here, this is different. So the impulse will come prematurely from an atrial site. So premature impulses come here. Because this is still ongoing refractory period, they are blocked. They find a way, get into the slow pathway. The impulses, some of them, the impulses will go down to the ventricle, and the other impulses will move upward retrogradely and start all over again, creating a reentry. So that is the AV node reentry tachycardia. Usually, SVT is narrow QRS like this. But if we have a bundle branch block, they will become wide and you think like they're VTAC. This sinus tachycardia, atrial flutter, and the AFib, if you make their heart rates go fast and have a bundle branch block, they will look like VTAC as well. They're wide complex. Okay, so we admitted the patient with this rhythm. And this rhythm shows a sinus rhythm with left bundle. With left bundle, because as we said with left bundle, V1 is down, this one is upright. But in this case, this is atypical, so don't worry. This is still a left bundle. 10% we have exclusion to the rule. Okay, so sinus with left bundle branch block. Suddenly, the patient developed this rhythm, and they are all wide complexes. Okay, but because the feature is the same from 1 until the end, they're the same. The only difference of these two is the rate. This is normal, this sinus, and this is SVT. But then the features are all the same. And if you look at lead 2 here at the green one, they're all narrow, and it is 0.16. This is SVT with left bundle. The other one is sinus rhythm with left bundle. So if I will compare this with a VTAC in here, there's a VTAC here example. Okay, this one here. Okay, side by side. So this one here, if you compare them, okay, concordance, yes. Negative concordance, yes, they are negative concordance. This is negative concordance. Okay, assuming I have no 12 lead ECG. Okay, if you look at the descent of the QRS in here, it's slick and it's fast. See, it's slick and it's fast. If you look at the descent of this beta here, it's slur. There is a slur or notch, so it's wide. So another feature to compare. Let's go to lead 2. In lead 2, we have here a fusion bit. I'm sure this is a fusion bit,